Now that she has been stabilized with our hemostatic resuscitation phase of transfusion, Keith, what are the pediatric critical care transfusion recommendations and guidelines from this point forward?
Once hemostasis has been achieved, we move on to goal-directed therapy. This involves specific component administration and is driven by viscoelastic hemostatic assays. This phase involves both volume support and directed components to prevent traumatic coagulopathy. pRBCs, platelets, FFP, and even cryoprecipitate are part of this phase, but we utilize them in different ways based on the goals that we are pursuing.
Okay. But Natalie, if we specifically look at red blood cell transfusion, what are the most recent guidelines for goal-directed transfusion?
This is a busy slide, but we wanted to include the most recent guidelines for your later review. We'll look more closely at a few sections of this. The very top line of this diagram describes a child in hemorrhagic shock who obviously requires transfusion in a 1:1:1 ratio. This is the hemostatic phase of transfusion we've already discussed. But now let's hone in on the critically ill child who's no longer in shock. Let's not forget the goal of packed red blood cell transfusion is to maintain oxygen delivery to tissues and prevent anaerobic respiration. Red blood cell transfusions are not used to treat anemia, defined as a decreased red blood cell mass. Based on these guidelines, anyone with a hemoglobin less than 5 should be transfused. It comes down to clinical judgment for anyone with a hemoglobin greater than 5. Stable patients with hemoglobin above 7 should not be transfused just because of any of the following reasons: critical illness, postoperative state, ARDS, sepsis, some non-life-threatening bleeding, need for renal replacement therapy. Consideration to transfusion in these patients should be given in acute brain injury and any oncologic diagnosis with bone marrow failure.
Generally, the recommendations seem to boil down to clinical judgment for red blood cell transfusion for most of our critically ill patients. Howard, if hemoglobin level and severity of anemia aren't great indicators, what are some measures that we can use to assist in our clinical judgment?
Our patient is in the hemoglobin 5 to 7 range. So we start with the oxygen delivery equation, DO2 on this graph, and the key elements of this equation are cardiac output, hemoglobin concentration, and oxygen saturation. Oxygen delivery will decrease with the decreasing hematocrit and constant cardiac output. But it is important to remember that at the cellular level, the main determinant of aerobic respiration is not exclusively oxygen delivery, but whether oxygen delivery exceeds oxygen extraction capacity. Oxygen consumption, or VO2, is dependent upon both oxygen delivery and oxygen extraction percentage and is conserved across a wide spectrum of hemoglobin concentrations, as shown on the next slide. VO2 remains relatively constant over a broad range of hemoglobin values, down to an apparent limit around a hematocrit of 10, which is approximately hemoglobin of 4.8, showing that cellular oxygen extraction compensates for a decreasing oxygen delivery and prevents lactic acidosis. So the bottom line, mixed venous oxygen saturation around 60% or 65% centrally is the limit of aerobic oxygen extraction at the cellular level, and a lactate greater than 2 suggests anaerobic respiration. These are the physiologic indicators that suggest a red blood cell transfusion will deliver a clinical benefit.